continuity, among other things. And she's going to talk about her work in Orissa on maternal health.
Hi, everyone. So thanks, Eric. My name is Divyan Ramachandran, and I'm a PhD candidate in the Department of Computer Science, working with Professor John Canny in the area of human-computer interaction. Can everyone hear me? I guess so. Okay. I'm going to give you a little overview about my dissertation work. Project called First Days. We're working on mobilizing community health workers to improve maternal and child health in India. And in case the title doesn't give it away, this is a mobile phone idea. So here's a map of the world that looks a little different. This portrays the number of maternal deaths that have occurred in various countries in the year of 2000, and that's the territory size is proportional to that. As you can see, this is basically a developing world problem. 99% of these deaths actually occur in the developing countries. And this has been kind of on the global agenda for a while of something that needs to be fixed. The 5th Millennium Development Goal is to improve maternal health, reduce it by 75%, and achieve universal access to reproductive health. And a similar map is that of infant mortality, and this has also been a Millennium Development Goal, reducing child mortality, cutting the rate by 2/3. So if you look at this graph here, what you can see is that there's actually a correlation between the maternal mortality and neonatal mortality and the presence of a skilled birth attendant. And as you can see on the right, a lot of these births are still occurring without the presence of a skilled birth attendant. In fact, in India, more than 60% of deliveries are conducted at home, and less than 20% of these are actually attended by health personnel. But mostly, I mean, if anybody, you have traditional birth attendants who are not skilled to deal with a lot of different complications. But at the same time, more than 75% of the deliveries that are actually conducted in hospitals are attended by a doctor, or at least a trained nurse. And there have been preliminary results that have shown that hospital deliveries could actually bring the number of maternal deaths down by a factor of 2. If we look at prenatal care, there's still 1 in 5 women in India still not even seeing a doctor at all during her pregnancy. And the most common reason for this is just neglection by the families, the husbands, who just basically don't think that it's necessary to get medical attention during this time. And it is important. It is important to identify high-risk pregnancies, and also, particularly in India, where over 80% of women are anemic, to identify that and prevent it, because it's a very preventable problem, and reduce this problem, which is actually the cause of 1/5 of all maternal deaths in India. In addition, women who receive sufficient prenatal care are 2 to 5 times more likely to deliver in institutions. So what have I been doing? I've been conducting some qualitative fieldwork in India. I started out in Tamil Nadu, and while I was there, I kind of realized I wanted to be in a state where the problems that we're talking about are a little bit more pronounced. And so I moved up to Orissa, and that's where I spent the last summer, talking to a number of health workers, communities in which they work, as well as a lot of organizations that engage in training these health workers. When I talk about health workers, I'm specifically referring to 2 different types of government-employed health workers. One is the accredited social health activist, or ASHA. She's employed to address most of the maternal health needs, and then the Anganwadi worker, who addresses a lot of the infant needs. Specifically, the roles that these Ashas and Anganwadi workers play are listed here. This shows the roles that the Asha is supposed to be doing, and here is the Anganwadi worker. The main work of the Asha is the thing that everyone talks about is she's supposed to motivate women to go to hospitals for their deliveries, and she gets money based on whether she does that or not. So it's a performance-based compensation. Anganwadi worker gets a regular salary, and her main job is basically to run a preschool and provide food, which the government provides for children, to identify malnourished children, etc. But there are a lot of discrepancies in the performance of these roles. As you can see, just from our interviews, these are the roles that they actually, on the left, under the W, that's what they actually said they do. And so you can see there are a lot of roles that they didn't even tell us that they were actually performing. And on the right, you can see what the community was perceiving that they were actually receiving. So these are the services that the workers are actually providing. And in fact, and this quote sort of talks about that we don't really know what the function of the Anganwadi worker is, and so we don't really know what to demand from her, and that's why people are not dependent on her. In addition, there's a lot of issues in the resource supply chain. The government is providing medicines and food for people, but the supplies are not always regular. And so here you can see two sides of the story. A village chief is saying, we know she gets these pills, but she just doesn't give them to us. We know this from the radio and TV, that's what we've heard. She doesn't give it to us, that means she's selling them on the side. And she says, the main problem I face is the irregular supply of grains. People react strongly to that. When I go to monitor the growth of the children, they say, why are you monitoring our children's growth? You're not feeding them. It's your fault. And they also face a lot of challenges within the household. They're targeting these young reproductive age women, but these women have very little decision-making power, and it's really important to target basically other people in the family, the mother-in-laws, who are really the people that control a lot of the decisions during a woman's pregnancy and birth or delivery. And but at the same time, it's also important to talk to the woman herself, because in the end, she has to take care of herself. She might not get that kind of attention from her mother-in-law. And so altogether what we see is that you've got the human resources in place. The government program is really trying to build local capacity through these community health workers to motivate the community to adopt certain behaviors, but they need help in persuading these community members to do so. And so what we are looking at is in what ways can we use technology, specifically mobile technology, to help the community health worker motivate the people in the community to adopt certain behaviors. And so what in the world are we talking about when we say a phone can persuade people to do things? So basically what we're looking at is how we can incorporate different ideas of persuasion, psychology of persuasion and influence, look at the different dynamics that are going on in the community and see how can we incorporate these ideas into a design that can, into applications that can basically support this that process. So let me go through really quickly how it is that we've been studying this. This is an experiment that we actually conducted here in Berkeley, and this is basically an example of how we believe we can design an interaction that can be more persuasive. So here is an example of the experiment that we did. Meet Alice. Alice is a teenage girl, and she has one goal in her life at this point, and that is to borrow her mom's car to attend a rock concert. And so she's thinking about two different ways in which she can approach this problem. She can walk up to her mom directly, just lay it all out there, tell her mom the details, what she wants, and just ask her for it. That's one possibility. Or she can go up to her mom and start by just saying, oh, hey, I want to go to this rock concert, wait for her mother's response, and then slowly bring all the information in until she finally drops the bombshell. So basically we decided to study these two different ideas. Which kind of interaction would be better? Which would be more persuasive? And should we present the information right up front or have short relevant responses to prompts? And we conducted an experiment, basically a psychology experiment, by designing two different systems which incorporated these types of interactions. A recorded message system and a dialogic system, and both were speech-based. And we hypothesized that the dialogic system would be more persuasive and found that that was actually true. In addition, we also hypothesized that the dialogic system would basically present less information, even though it would be more persuasive, and we found that that was true as well, with statistically significant results. So how does this matter? What can we do with this? So now we're studying basically different ways in which we can design persuasive interactions on one side, but at the same time we actually need to present information that's relevant. And so on the other side, we've also been working on sort of content generation. Who do we talk to about what are the topics to address? What are the ways in which to present information? What's been happening in the field as well? So for that, we've been partnering with this organization near Chennai. We've most recently conducted a 2-day workshop with a bunch of NGO health workers and trainers, and talked about sort of what are the processes through which they tend to now teach information. They do a lot of reproductive health information training, and then sort of brainstormed a number of different issues. Topics in maternal health, generated a lot of stories that they generally tell. We even had them design sort of TV advertisements on paper and different paper prototypes for some of some commonly used methods that they use for teaching information. So now, with this, here's one example of an interaction that we're talking about. Like, what can we give these health workers in order to sort of facilitate their discussions with the community women? Here's an example where you have a story. You're basically watching a sort of very simple animation on the phone where two people are discussing something that's happening in their neighboring house. This man is beating his wife. Why doesn't she just run away? And she's listening on the other side. She's trying to decide what she should do. And at that point, the user actually gets a question. What do you think she should do? And just engaging them in the story, letting them sort of control the outcome of the story and engage more in the information that's being taught. And this could facilitate more discussion between the user and the community health worker. So we've also, I'm not going to go into this in detail because I'm probably out of time, but basically we've been looking at a lot of different factors of influence in the psychology literature as well, and trying to look at how it is that we can incorporate these as well into this design. And so these interactive stories do incorporate a lot of these sort of psychology measures as well. So the work we're doing right now is basically designing prototypes for testing in India right now, and we're thinking of planning for testing in early spring. And we've also found a couple of target sort of reproductive health outcomes that we're trying to get, things that we can measure before and after our intervention, institutional deliveries, prenatal care, the iron pill consumption for anemia, and then the immunizations. All of which are tasks that these community health workers are supposed to be doing already, and we're just going to be seeing in what ways can we use technology to facilitate that. So in summary, we have the human resources necessary, but the delivery of the services is still weak. So what can we do to where we see that the health promoters are limited in their effectiveness within the community because of issues of credibility and other things. And so we believe that we can use tools to help those health promoters become more persuasive, and we think of mobile technology as a promising platform for delivering these kinds of information. So thank you, and are there any questions?
Hey Divyan, so I was wondering if you've looked at broadcast technology at all and persuasiveness, because there's a lot of literature on soaps in India,
yeah,
and their impact on maternal behavior, gender preference stuff.
In fact, I haven't looked at that kind of literature. I do believe I've been looking at sort of general, more marketing types of literature as well. But specifically on soaps, I do know, at least anecdotally and from experiences, that they do have, like TV would have a lot of influence. Information that's presented on TV, especially through these kinds of stories, would have a lot of influence. I do think that is another place from which to draw a lot of inspiration, especially in these stories. Any other questions? Oh, there's one up there as well.
I just want to follow up a little bit on that. So, I think I'm high up here, everyone can hear me. Following on from that question, is there a reason why, as against radio and TV, you think mobile phones are the most appropriate way to deliver this content?
Yeah, I think that television and radio is a fantastic way of persuading people. I completely agree with that, and I believe that's true. I do think, however, in this particular case, we're trying to facilitate the role of, basically trying to help the health workers in the work they're doing right now. Because those human resources are there, and they're supposed to be delivering services in addition to sort of providing persuasive messages. And I believe that mobile technology is a good way to do that, because now you have these health workers who are supposed to be going from house to house, visiting these pregnant women, talking to families, and they're supposed to be doing all these things. And it is added effort for them to be also trying to facilitate, say, group discussions, getting everybody. They're not just now persuading people to take iron pills, they're also persuading people to come to maybe a center where you can provide, where you can show this kind of information on a television, or you can have a group discussion and that kind of thing. So I do think that there's a lot of there's a lot of reason for specifically using mobile phones to target the health workers. But I don't necessarily think that this is necessarily a more persuasive platform to deliver information than, say, TV or radio. So it's really has to do with fitting into the work practice right now that the health workers are doing.
Yeah, I think another point is confidence. I mean, whenever you have a person, somebody that you know personally who is talking to you about something, you tend to to listen more than if it's said over the radio or somebody just some kind of broadcast channel. I think that, especially where I come from, it's very relevant when somebody who you know talk to you. And I think that this direct dialogue between somebody, especially if they are known in the district and the woman, will be very effective in this sense.
Yeah, and right, following up on that, I mean, television, of course, supports a lot of one-way communication, and radio, of course, Ravi has done work and others with community radio and making it a two-way communication thing. But really, the reason we're looking at mobile platform is to have a platform that supports a lot of the kinds of interactions that you can use. You can actually engage people in, and they can talk to it and get responses back and that kind of thing. Just more personalized information, in addition to sort of having a person they know facilitating that discussion as well.
So one of the interesting things about this to me was that you're doing a sort of personality test prior to trying to convince someone of something. Is there precedent for this that's shown it to be more effective in doing your convincing?
I'm sorry, I don't think I understood the question.
You had this thing where you sort of asked them to respond to certain scenarios, and from that you can sort of derive, how something about their personality, about how what they think about certain social situations, right? And so that seems to be effective in telling you who you're talking to, and thus shaping your approach to convincing them to seek prenatal care or whatever, right?
Right.
So has this been done, I mean, without necessarily the technology, has this been done before, where you sort of give someone some sort of personality test and then based on those results try and convince them of something? Yeah,
I think a lot of sort of the idea of when you want to tailor information towards a person, it is a really sort of it's a kind of a common practice to get information about sort of a baseline, to know sort of what kind of information you particularly want to target to them, so that it feels more personal and it feels like it's actually targeting the individual rather than just having some generic information. I'm not sure if I completely understood your question, but I think that's another sort of area to look at, is sort of gathering information from the user themselves, and so then through that understanding what information to present to them. I don't think maybe I should talk to you offline, because I don't think I answered your question at all. Okay.
Could you please describe how you envision the system actually working? So would the health worker be talking to the, the mom over the phone, or with prompting of content that would be on her phone? Or would she go and visit someone and then, could you please describe? Thanks.
Yeah, it is definitely a face-to-face interaction that we're trying to support here. So you have the health worker who's already, she lives in the village in which she works generally. And so she's already supposed to be making house visits, talking to people, trying to convince them that they should be taking their iron pills, getting their immunizations, or telling the mother-in-law, you should be planning to have this delivery at the hospital. So she's already doing that kind of thing. It's just that it's been hard work. Sometimes she faces various barriers of the community because of that. And so the envisioned interaction would be that she's still doing the same thing. She's still doing the house visits, but she doesn't have to do all the talking. Once in a while, she can just sort of stop and say, look, it's not just me saying this. Here's some more information that's sort of supporting what I'm saying and helping her build credibility in the information that she's trying to teach.
All right, thank you very much.